Thank you so much for joining me today, Hannah.
Thank you, Lucy, for inviting me. Yeah, it's been long coming, hasn't it?
It has. I particularly, if I go back to our LinkedIn message, I think you sent something quite like, I think I'm ready to talk now on LinkedIn, which I hope that means that the audience, even though we haven't introduced you yet, that might make them be as excited as I am to find out what you're going to tell us. But on top of the big intro I've just done, how would you like to introduce yourself, Hannah?
Right. So I find introducing myself very interesting, like many other people. And if I'm to use one word to describe myself, I would say I'm a mosaic. And when I talk about that pictorially, I think about the Birmingham New Birmingham train station. Where you have this mosaic on the ground of the woman who fought to vote. What's the word? It starts with an F. I'm trying to remember.
As in like a single person or like the
Yes,
suffragettes?
the mosaic. I mean, I had it. I've just lost my train of thought.
I'm
So the
looking it up. I'm looking it up.
Yeah. So if you Google it, you would find a mosaic, little collection of pictures of women, and it's on the floor of the Birmingham New train station, and as the woman who
Oh,
fought to vote.
so it's called. So I don't know this, but Google AI, which I'm not really a fan of, but anyway, it says Birmingham New Street Station features a large mosaic called "Face of Suffrage," depicting Hilda Birkin, a
Prejudice.
suffragette and community-led
Yeah.
mosaic is being created for the new University Railway Station.
Yeah. So that is how I'd like to describe myself. Little tiny bits of it, which come together. So back to the question you asked, who am I? I am a Black woman. I'm a mom. I'm a wife. I'm a daughter. I'm a sister. I'm a friend. Very eclectic, made up of different things. Now, what do I do? Which is very different from who I am. So I wouldn't. When people ask me who am I wouldn't say I'm a GP. But what I do is that I practice general practice, and I work as a portfolio GP, which includes everyday seeing patients face to face. And I do have other special interests like occupational medicine, occupational health, women's health, prison medicine, and substance misuse management.
Brilliant. Yeah, so I love that because we were saying at the sort of top of the podcast that everyone is made up of so many different types of parts of themselves, and trying to do an introduction is, where you sum that all up is very, very difficult. And you might be bringing different bits of you to different parts. You might be showing a different bit, like portion of the mosaic, depending on the situation you're in. So, for our audience, what is a portfolio GP?
Well, so you could define portfolio GP as a GP who does other things beyond the regular 9 to 5, seeing the patients in the clinic setting, like in a community GP. And I've described earlier what makes up my portfolio. It's the prison medicine, it's the occupational health, and the special women's clinic that makes up my day job that comes up together to form my portfolio as a GP.
So you're not doing every day clinically, sort of taking appointments and everything. And I think when I was in medicine, there was this idea of as if being a portfolio GP meant that you're not working hard enough because you spend a day doing something else. Do you know what I mean? But now that I am doing medics for rare disease, I don't practice anymore. I really understand that it's important for our NHS that we have people coming through the system, becoming leaders and learning from not just from sitting in the same room every day doing the same kind of clinics. What do you find the portfolio side of your career adds to your clinical medicine?
Absolutely. So the NHS treats a certain kind of people, and it's just fair that these kind of people that we are managing are, I mean, the people that we manage or the people that we are seeing is reflected in the kind of leadership who arrange the treatment plan for these people. I'm not sure if I'm making myself clear. So, for instance, in the NHS, we are making plans for people with disabilities. We are making plans for people with rare disease. And it would be, for lack of a better word, say unfair to have people who are not disabled to make plans for people who are abled, because they don't quite get the picture. They don't quite get the image. It's different. So it's just fair that at the various helms of affairs, the people who are representing the end users of the system are representative of the people at the end tail of the product.
Yeah, definitely. So people who, so it's not that you, I think traditionally there's been this view of you kind of like work and work and work and work and work clinically until you get to a senior point of view. And then at a senior place, you start making decisions for everyone. But I mean, we can get into how well we think that's worked so far, but I'm not sure that, traditionally, for example, medicine and senior roles in medicine have largely been made up by men. And I think that's still the case. And look at the recent problems we've had them for a long time, but that are emerging and becoming visible around menopause. But if you don't have people experiencing menopause, designing services or putting their input, that's inevitably going to happen.
It's interesting that you bring this up because, yes, traditionally, medicine was supposed to be for the middle aged, able man. And as the years have evolved and things have changed, it's trickled down to actually, I would reframe it. It was made for the able, white, middle aged man. And now things have changed. So now we have people of color, we have a lot more women. I think I recently read that there are as many females as men now in medicine. And the last time I checked from the GMC, it said that currently they are, from their latest data, they have as many international medical graduates registering from their latest data as locally, or people who had their primary qualification from the UK. So it's almost like we are at par. So yes, generally things have evolved.
Yeah, so the demographics in the staff have evolved. And if you one hopes that then you really make the most of those differences and that people have so that we can get a better, that what we provide to everyone in the NHS is more suitable for the beautiful variety of people that we have in the country. So yeah, go on, honey.
No, because generally the United Kingdom has become more and more cosmopolitan, or very eclectic, let me say, because now we have lots of people. There's been a huge push on immigration over the past at least 5 years, maybe more. So we have any and everyone now in the place. It's now a proper melting pot of different cultures. I'm yet to think of any country that you might not find a small community of them here in the UK today in 2025. So it's just fair that when they come to receive healthcare, they would have people who, if not exactly like them, at least represent them and make them have that feeling of well-being with
Yeah.
respect to healthcare.
Which reminds me, it's Eid today. So I'm not Muslim, but Eid Mubarak to anyone who's listening. I mean, it's not going out on Eid, but that alone, I studied medicine in East London, and things like, I was at an adolescent psychiatric unit, and Eid is a huge festival for millions of people. And being able to accommodate that within people's care, because that's a really important part of themselves. I also worked in Homerton, where there's a really large Ashkenazi Jewish population. So thinking about how that community are able to appropriately access healthcare on the Sabbath, etc. So yeah, wherever you go, there's always going to be pockets of different communities, but also even people. I'm atheist to the absolute core, but I have my own value system. I have my own. It doesn't mean I don't have any values or morals, and I don't celebrate anything. But everyone is different, and being able to sort of learn and accommodate that is really important. But you like you said, you're a mosaic, so what do you think? What are your passions? Because you've taken a bit of a different route to medicine than say I did maybe.
So, Lucy, an interesting aspect is that I didn't choose general practice. I would say general practice chose me. And my particular niche now of what I do in terms of occupational medicine and women's health, again, I dare say it chose me. I'll give you a background story to all this. So I had come into the United Kingdom some 10 odd years ago. I'm originally from Ghana, West Africa. I'd finished medical school. I had done 2 years of foundation years equivalent in Ghana. So I'd moved here to do a master's in public health with the aim of going back to Ghana to, change the world and with all the big bright ideas. So I'd moved here bright eyed, bushy tailed. And at the tail end of my master's program, I just started feeling a bit more tired all the time. At that time, so I had taken my PLAB, which is the transition exams, the medical licensure exams for the United Kingdom, and so I could practice even though I was doing my masters in public health. And I picked up a locum in cardiology, and I had this consultant. He had only known me for a couple of weeks, but he could see that I was a ball of energy as an SHO. I was up going. And compared to my healthcare system, what I was used to and what I was doing here, when I heard people complaining, especially many of the foundation year complaining about the workload, I will just smile to myself because my clinics back in Ghana were about 50 people between 9 and 5, and I was a one-man job. I had to do it all by myself. So coming here and having a ward, and we would just do like a walk around, ward round, and to me it was nothing because I had had a proper baptism of fire back at home. So it was really, no job for me at all. So I was just up and going. And then after lunchtime, I was struggling to keep my head up. So I'm not going to use technical terms. I had one of my eyes drooping. I noticed I had a slurred speech, but I thought maybe it's in my mind. And my walking, was a bit more difficult. My gait was a bit more fumbled. So this gentleman had noticed, and then he asked me if I had noticed too. And I said, yes, I had. So I was just a bit more tired. I had these obvious symptoms, but I had been plodding on because I didn't, being an immigrant, being in an environment, I didn't want to be the problematic person. I didn't want to be the one who was complaining. So I'll just plod on all the time. And then when he pointed it out to me that, well, I think you should get checked out. I finally made a GP appointment. And when I went, I was a medic myself, obviously. So I had a few things that I was thinking about. My worst fear was that, well, I would rephrase it. I knew it wasn't a stroke because it would come and then it would go. Because I couldn't think that there could be anything worse than that, to be fair. And generally, I didn't have any positive family history of any disease. I don't have any chronic condition myself or in my family. I had always been well and hearty. And I was the kind of person, when I moved here, I would go to the gym twice a day because I was a young single girl. I had no care in the world. So I'll go to the before going to work. And when I close from work, I'll go to the gym. And then I went to my GP, and then he says, oh, let's count 1 to 20. And I couldn't. I was slurring. And then he says, okay, try and flap your wings for me. I was tired. I couldn't. And then he said, well, yeah, it's unfortunate, but I'm thinking that you might have myasthenia gravis. I have to refer you to the neurologist. And I'll tell you what, Lucy, I saw this GP, I think, on a Thursday. And you know how things roll. You wait for a neurology appointment. Mm-hmm. By weekend, I had my first crisis.
Oh, wow.
Yes. So in a way, my diagnosis got expedited because I had the ambulance coming for me from my house. I was in the high dependence. Well, I was in the ICU. I was degraded into high dependency. I got ventilated and all that. And then, even then, after I had been through that whole rigmarole, I was still in denial.
In what way?
I couldn't believe, it all looked like a movie. It looked like that's not me. That couldn't be me because a few days ago I had gone to the gym and there was nothing wrong with me. And then now all of a sudden, instead of me seeing patients, someone was seeing me. So I had to be on the other side of the. So it was surreal. I couldn't. It was. I was just watching everything go past. I had never been on hospital admission to the best of my recollection. I'd never been to the hospital to, as in being on a hospital bed, maybe other than me lying down for my friends to examine me in medical school, but like in real life, I'd never been in that position before. So that was daunting, and just just putting myself together to believe that yes, this is a life-changing diagnosis. There were a lot of questions going through my head. So first of all, I really love kids, and I was, and no one could explain to me, it sounded almost like I was being stupid when he said, so this neurologist comes round, I'm receiving IVIG. And then he says, yes, you have acetylcholine antibodies, it's positive. And yes, we think you have myasthenia gravis. Have you heard about it before? And I'm thinking, I'm a doctor. And so I said, yes, I've heard about it. And he says, well, I don't know how much you know about it, but just here's an information leaflet. And then he gives me an information leaflet and he says, at the bottom of it, there's a number for a myasthenia nurse. You can call her and then she can fill you in on anything else. You would have to be taking these medications, you're on steroids, you're going to be on this and that. Usually people have a good life expectancy, but let's see how it goes. And I had lots of questions to ask him. I was on a visa. I had just moved into this country and I was on a visa. And on his way out, he stopped and he said, well, you know what? People who get diagnosed within the first year do benefit from having a thymectomy. And he just said flippantly, and yes, your CT scan said you have a hyperplasia in your thymus. So it would benefit for us to think about removing it.
Yeah.
So and all this was within like 15 minutes. It was a lot of information. I had a lot to process. I had moved into the country by myself.
And
I
you were on your own? Were you on your
I
own?
was on my own. I didn't have friends. I didn't have family. I wasn't married. I didn't have a boyfriend. Nothing. It was just me as a student. And I wasn't sure if I wanted to tell my friends about this. And who are these friends? These were friends that I had made in the past
Yeah.
8 months. Were they friends?
Mm.
Did I want to burden them with my own condition? These were difficult questions that I had to ask. And did I mention that so because I was doing a master's in public health, I had gotten an internship to do in Geneva with the WHO. So I'd gotten my visa for that. Everything was on the roll. And then Geneva wanted to know, when are you starting? And I'm thinking, wait a minute, I'm not sure I'll be coming because my life is a mess. I don't know. Everything I had planned has just been turned upside down with a 15-minute conversation with a lot more questions than answers.
Gosh, I mean, so you've been in the UK for what, 8 months? You've got this plan. So you're a doctor in Ghana. You're doing a public health master's, doing a bit of work as a doctor in cardio, and then you were planning to go work with the WHO in Geneva, which I mean, that sounds brilliant. Like, but now you're having this sort of like a complete turnaround where you're the person in the bed, you're receiving the information.
Absolutely.
It sounds like you were kind of having a bit of an out of body experience or something.
It was surreal. It was surreal. I mean, I could, and unfortunately, so the IVIG is a 5-day treatment. So minimum for each crisis, you would stay a minimum of 5 days. That is assuming your body picks up. And it usually tends to be protracted stays at the hospital. So 12 days, sometimes 14 days. Not to talk about food, because I'm a person of black origin. I like my food nice and spicy. So I get used to bland hospital soups, hospital attacks, long cold nights. But then somehow, but that's the price you pay for your health. But these are all things that perhaps could have helped with recovery. If we could think about these other factors, because these are silent factors. Someone would think that. I'll tell you one particular episode, Lucy. So earlier in January this year, I had another crisis, unfortunately, and I was at the HDU, and I stayed there for about 5 days. And for the first 3 days, nobody eats at the HDU. If anybody has been there, so at the high dependency unit, nobody eats. So I was just getting better, and then I realized I was hungry, and I told one of the nurses that, oh, I think I'm hungry. And this is a very lovely Caucasian nurse. And she says, oh, I'm really sorry, Hannah, but we don't even have the food list come around here because nobody here eats, obviously. Everybody is either intubated or having parenteral nutrition. But it was a Friday. She said, the staff here, we are ordering some fish and chips. So I'm going to put your name up on the list. On a normal day, Lucy, I don't like fish and chips. But that fish and chips, after 3 or 4 days of not eating, was probably one of the best food I had eaten ever. And it was just because of the kindness that was associated with it,
Yeah.
that she would go out of her way and say, I'm going to buy you food. It was
Yeah.
probably a fiver, but it meant the world to me.
I think, food, faith, family, all the F's. These are what make us kind of who we are. And I think that we know. Like when I was at medical school, we were aware that these things are really important to make sure that people recover well, that so much is, these things are important to people. And it's quite interesting because I actually did a placement in hospice, so with end of life care or people who have life limiting conditions and they're having treatment for symptoms, and they would do it amazingly. And what they would do, and I did often think to myself, maybe if we applied this level of holistic care to people when they were living, they would be dying in a more healthy way. So they really adhere to sort of any cultural, spiritual, personal values, food and what people like, how they like it is really taken care of. I know the idea of that seems massive in sort of acute care situations, but I think when someone is living with a rare condition, it's usually lifelong and chronic. They're often going to be needing to go into healthcare settings. They're not end of life, but the whole point is when someone's end of life and they're regularly using healthcare, we try to make it, or say someone has cancer and they're being managed or something, we have a whole system for them because there's this understanding that they're going to be regularly making contact with healthcare. They're going to need maybe platelets every week or chemo every week or something like that. And therefore they go to a place where there's a space for them. They know the people, they know their desires because it becomes like a second home for them. And it feels like that's what's missing in rare conditions that are lifelong, but not necessarily always life limiting, but also that might relapse and remiss, etc. But when you go in, if you need 5 days of IV immunoglobulin, then that is a significant time to be spent in an institution. It's not an overnighter that wasn't expected, is it? And that's kind of where I think where people living with rare lifelong conditions fall through the gap in our NHS.
Unfortunately, so yeah. Unfortunately, it is. And for many of these rare disease, it's not curable.
Mm,
So even that burden of knowing that, oh, I have a condition that is not curable, because again, the statistics of the people who are burdened by the disease is small compared to the general population. There isn't as much research into them. So it doesn't quite look like, unlike diabetes or other conditions that every time the new medications are being made, for us, it's a bit slow.
yeah. Yeah, and while things are slow when it comes to treatment, we need everything else to be in place because
That
if what we're if what is happening is okay, there's low numbers of patients and therefore it's difficult to find it's difficult to get the data, it's difficult to work out if you're trying to work out a new molecule for a new treatment, it's it is costly. It is likely to fail. It is all of these things. Plus, you have a low number of patients to test it on who are just as diverse as the diversity you get in a commoner condition. Just because there's fewer of them, it doesn't mean they are all the same. And so it can be really difficult. But doesn't that say all the more that therefore we should be looking after the things that we can do?
And that is where I say my career chose me, I see my job as more of a calling because I've been there. I'm one of the few people who has the rare opportunity to see things from both aspects. Because on Monday, I might be your GP, but on Monday evening, I might be the patient, you know. So it gives me this rare perspective where I get to see what did I not like when I was on the other side of the table? Did I feel fobbed off? Did I feel not listened to? Did I feel like she was just saying, yeah, yeah, so that I would keep quiet? When I said no, and you never get the line from my left hand, and she said that she was going to try anyway. How did I feel? And on top of that, so it's a long, convoluted story, but one of the things that fueled me to go and do occupational health or to pursue a diploma in occupational medicine truly was to pay forward. So during my training as a GP, because of my personal condition, I had long protracted times off work. And getting back into work, I had to wait for occupational medicine to write me a letter to say that I needed reasonable adjustment. Sometimes it wasn't really anything big, it was to say, hello, this patient suffers this. And so she might need to sit every now and again. And for surgical routine, she might struggle with repetitive actions because my muscles get weak. And so could you exclude from that? But this seemingly simple letter was a make or break for me. If I didn't have these letters, I couldn't have completed training. And sometimes the waiting time for an appointment could be as long as 4 months. That's like a whole rotation. Me sat at home doing nothing, waiting for a double adjustment letter. And it's funny that people think that, oh, because she's unwell, she doesn't want to work. No, she wants to work, but the environment doesn't enable her to.
Yeah. I mean, Hannah, you said that you came over, you grew up in Ghana, you did your medical education, your training in Ghana, always been fit and well, and came over to the UK. It's quite interesting that you were working in the UK as a doctor, having never sort of used hospital services at all. And if you look at the recent NHS staff survey, we still have a major problem with people who are immigrants who work in the NHS being discriminated against and being abused in the UK. And now you now have living with a rare condition. You really, really want to work, but again, there's a barrier to getting the sort of sign off that means that, okay, you can work. It's just that you might need an adjustment here or an adjustment there. And again, it's that there's this kind of, I think it's right, quite interesting that in yourself, not that I want you to have to epitomize all of these things, but there's all of these sort of rhetorics out there around people who don't work not wanting to work. It's because they don't want to, but it's because they're lazy or something like that, rather than they need an adjustment so that they can work. And it's not an off and on tap. It's not work no work. You don't There aren't two ways in this flow chart of work or not work. There's a huge middle ground of ways that we can adjust work so that people can get back to work, which is actually a law under the Equalities Act of 2010. And if employers don't provide reasonable adjustments, then they could be taken for a tribunal. But it's this is that frustrating to you? Like, if I were you, I'd have to never look at the press and never listen to the radio because the parts of your mosaic of being an immigrant who lives with a rare condition. Imagine if someone pictured that based on what is put out there versus yourself, Hannah, who is an incredible doctor, advocate, woman, all of these things.
It is. Well, to be honest, I don't quite listen to the news. I try to really filter what I receive. So it would it would take a lot for me to glance to, because I mean, everywhere you go, you hear a lot of bad vibes, from the being
Mm,
a GP, people with disability. Recently there's been a cutback on benefits to
mm.
people and trying to force them to go back to work. And I'm thinking, oh, well, yeah. So
You
it's
just you just sort of I guess that's the whole point. If you've put up with it for a really long time, you don't notice it, or
I wish I could say I don't, but I do.
you do, yeah.
I do, yes. It's just that I have good filters. So I
Yeah.
know, the circle of control, I stick to it, that what I'm able to control and what I'm not able to control. And yes, I just feed myself with things that I find uplifting.
Yeah. Well, what do you find uplifting then?
Having such conversations that throw more light on what we can do beyond the crisis. It's
Mm,
bad if we can sit, Lucy. We could have sat here, and I could give you a plethora of things that I have felt was not done right to me,
mm,
or how I think the system has failed me, or how I think things could have been done better. And so what?
mm.
you know. But like a phoenix, we rise out of our ashes. I was telling you about how I currently work in occupational medicine, and it's come because of these supposed bad experiences that I've had. Same with my experiences or my pursuit in women's health. I had my last baby in 2022 in the Midlands. I'm not going to mention the name of any hospital. And because of the myasthenia, I was in hospital having one of my. So it was supposed to be an elective surgery, and I was supposed to come in, get optimized with immunoglobulin before I have the elective operation. And whilst I was having the optimization, I went into labor. I told them I was in labor. I was not a primary parent. I'd had a baby before. So I knew what labor was. And I kept saying, I'm having contractions. So because I was on the neurology ward, they said, well, we have no idea about labor, and that would organize for obs and gynae to come in. It took a day for obs and gynae to come in. And all this while, I was having contractions. And then neurologist said, well, unfortunately, you only came here for IVIG. And so we don't have any pain relief for you. So the best we could do is some paracetamol. And again, because of myasthenia and the long list of medications that you will not be able to have, we are not sure. And I said, well, you don't have to be sure. You can ask someone. So back and forth, I was in labor for close to 72 hours. And tell you what, by the time that finally I got an anesthesiologist to come, and OBGYN and the whole team came over, I was 10 centimeters dilated. And they said, well, we're really sorry, which I've had lots of, you know, it's almost lost its meaning when someone tells me they're really sorry. We are really sorry, but we know you're 10 centimeters dilated, and now you're getting more fatigued. So just so that we prevent any harm to yourself or your baby, let's go in for a cesarean section. And I'm thinking, I had to go through all this pain only for me to have the cesarean section on top. And I have lots of questions, was it because I'm black? I thought I could self-advocate. I thought I had a voice. I thought I could say that I was in pain. But the truth is that after saying this for some time, you save your energy,
Mm.
because you don't want to be labeled. At a point, I felt like, am I drug seeking? Is
You
it?
you thought, are you drug seeking?
Yes,
Why
because
did
I
you think
thought,
that?
because I was in pain, but then again, I felt I was being gaslighted. So I said, am I not in pain? Yeah, but I'm in pain. I'm having contractions. Is paracetamol good enough for labor? You know, well, maybe it should be good. Because after some time, when you get ignored so much, you start second guessing yourself.
You
You
say
start, You start asking, oh, maybe everybody should be okay. Why am I not okay? Am I the problem? But no, you're not. If you are in pain, you are in pain. If things aren't working right for you, you should be able to voice it. Say it up until your last breath.
It's really interesting to me that you thought, am I drug seeking? What, like,
Because,
as in, I don't think that would ever enter my head. Does that make sense? Like, I just don't think that's a, hey, look, I've got enough hang-ups. I've got enough of like having felt, I would like, am I being a Karen? Because, or something like that, white woman wanting attention, talk to the manager.
yeah,
Isn't that really
yeah.
interesting? But I don't think I would ever have thought to myself, am I drug seeking? Why?
Actually, it did come up from one of the nurses who came to see me that, yeah, that's a typical thing that doctors do when they're in the hospital, you know. When they're in the hospital, they just really want a lot of medications. And I'm said, which lot of medications have you given me?
So someone put that in your head.
Yes.
Mm.
And
Yeah.
and even worse, I mean, I've had someone tell me, a neurologist, well, actually, he was a neurology registrar, who said, well, you know how your symptoms recover really quickly after you've had treatment. Well, we just have to rule out functional neurological disorder. And I said, what does that mean? You
Yeah.
know, I have cholesterol positive antibodies. You know, what do you mean? What are you trying to say? So yes, sometimes it's sad that as healthcare professionals we should treat people like that.
Yeah, I mean the whole drug seeking thing. Just we've done quite a lot of talking to Sickle
Mm,
Cell Society about why is it that despite standards, guidelines, a very well-known condition like sickle cell, how it is that we still get young men usually dying in sickle cell crisis and having to go to coroner and everything. And one of the things that does come up is this idea that staff thinking that they are drug seeking. And I would love it's hard, isn't it? Because that's the thing about intersectionality is that you cannot divide someone up. They are their whole selves. So, is it because this is a rare condition, sickle cell disease? Is it because it's a rare condition, myasthenia gravis? I mean, neither of those conditions are ultra rare. And we have whole highly specialized services for ultra rare conditions that manage, provide incredible services to people where there's maybe only 60 people in the country. So, myasthenia gravis and sickle cell are not those. There's lots and lots of people with these conditions, even if they are, say, rarer than type 2 diabetes. But I mean, what isn't rarer than type 2 diabetes? But so is it? But then hang on, but these are rare conditions that I learned about in medical school, which is better than the majority of rare conditions. These
yeah,
are rare conditions that have specialists in them, which is better than the majority of rare conditions. I mean, if you're there with a neurologist, maybe you'd hope they have quite a lot of knowledge about myasthenia gravis, but you can't be cut up on that ward as okay, Hannah, the person with myasthenia gravis, and Hannah who's pregnant. You are one Hannah, but also you can't be separated from the color of your skin or your immigrant status. And the reason I draw this is I can't believe you said like I thought I was drug seeking because the one other place where you hear that all the time is in sickle cell, and sickle cell in this country mostly, not always, is impacts people with an African and Caribbean heritage and their skin is black or brown.
yeah,
So what ties those together? That's the color of your skin.
absolutely, absolutely. And I mean, I've written a few reflective pieces about this, and I'm happy that we do touch on intersectionality, and the need that unfortunately we cannot dichotomize, or we cannot separate ourselves. It's still one and the same. And like my introduction about saying that it's a mosaic, It's all these little bits of the person, So it's the gender, it's the race, it's the disability. It all comes together to form the person. And unfortunately, all these ones tend to be amplifying factors for management, for pain management specifically, because technically myasthenia doesn't leave you in pain. So I've never had to struggle with asking for pain relief. But this is me in labor. So I'm sure at the time that I was asking and I was being given paracetamol every 4 hours, so probably like 6 or 7 centimeters dilated.
Yeah. I
And
mean,
I'm sure my grandmother, who had her labor in Africa, probably had better pain relief than I did in 2022 United Kingdom because I was black.
and also yeah, and also pain is pain. Pain is what the person says it is. But also in this situation, there's a baby and you have myasthenia gravis, and it feels like there as much as design of system might cut someone up into sort of body systems. There's another patient here. That baby was over 24 weeks. They are a patient. There's someone else in this picture, and therefore not only you haven't got a one patient situation, you've got a chronic condition on top of pregnancy. So
Yeah.
again, it's this kind of it's the fact that the system is made based on providing services, not on how people actually exist and live their like lives. Well, we have spoken for a bit now, and I realize that you are potentially going to be getting tired because I've been using your time. But before we finish talking, is there anything that you would like to stand on your soapbox and say without me interrupting you? Is there anything that is really passionate to you that you would like our audience to know or understand or think about?
So I'd like to do a little bit of imagination. So cold winter day, you are lying on your bed. You do have a duvet. It's not that you don't have, but your duvet feels like lead. It feels so heavy. It's not any different duvet, probably your king size, but it feels so heavy you can't drag it to cover yourself. And that's how myasthenia can feel on a day-to-day basis. Because of the extent of the muscle weakness, even the smallest things like your toothbrush feels like you're carrying a brick of cement. And so to be doing that repetitive action, it's almost impossible. I just entreat people to be kind, because it almost sounds like, oh, that's another mundane statement, but then not all disability is visible. Not all, I mean, you don't, it's a shame we have to go, Lucy, but I realize that on days that I use my walking stick, people tend to be kinder than on days that I don't. People are more likely to hold doors for you and say, are you all right? Are you okay? But on days that I don't, people will literally shove me off because I mean, I don't know what I'm supposed to put a badge on, but let's all be kind and let's all be human together. Because when I think about humanity, I think about humans as kind people,
Mm.
not beasts or mean people.
Yeah. Yeah, there's a Nick Cave song. I know it from Shrek, but I'm sure it's a great song anyway, where people they ain't so good or
That's a
something like that.
tendency, but no, I
I
see good
think
in people.
I think people they ain't so bad.
They aren't so bad.
I
Yeah.
agree. I agree with you. Well, Hannah, thank you so much for your time, especially as I know you've got a little one hanging around and that you've got to be careful how you use your energy. So I'm really grateful that you used it on us. So we'll say goodbye.
I thoroughly enjoyed the time with you and thank you for making me reflect on certain things. Yes. And again, we are good people. We are humans. Let's focus on that, the good part of us.
Thank you so much, Hannah.
Toodles.